the entire length of the video is under 10 minutes, because above 10 minutes you can't upload on Instagram or LinkedIn. Therefore, things will be a bit quicker than normal, but hopefully it won't take too much away from the procedure. So the first patient attended with bilateral, very dry earwax, quite dark. You can see the patient has got a bit of otitis externa, a bit of dry skin around the edge of the ear canal. So you can call that a bit of psoriasis if you like, or eczema of the ear. This type of wax comes out in pellets. Unlike big soft plugs of wax that are attached together, this type of wax is quite loose, so when you suction it comes out in pellets. It's the best way I can describe it. In fact, when we do our clear wax training, we do have little pellets that we put into the mannequin ear and ask the delegates to suction out. There we can see the eardrum is intact, slightly dull but slightly opaque, but there's a light reflex there, so that's okay. You can see the patient's just been scratching on the anterior canal wall. You see a little red mark, and that's because of the eczema, the otitis externa. It can cause a bit of irritation. So what I'm trying to do here is trying to peel off all this dead skin for the patient. This skin can crust, and it's not naturally going to come out. It's died and it's shedded, but it's just remained on the canal wall. There's that little red scratch mark. So I've used a full Zollner suction probe to gently just lift it. You can see I've gone all the way around the ear canal, just lifted it off the canal wall, just elevated it, and then I'm using a fine end suction tip. We're going to peel this away. We can never get all this dead skin out, and we've got to be careful. We don't want to be peeling off fresh, undead skin. So the skin is very important in the ear canal. The outer layer of skin, this epithelial layer, it provides a protective barrier to the deeper part of the ear canal and the skin layers underneath. The skin also contains a lot of keratin. So keratin is a protein, same protein we find on our fingertips or hairs. And keratin is not only hydrophobic, so it provides a waterproof barrier. So if water does get in the ear, which we're trying to avoid, it should just kind of roll out. Keratin also helps reflect away UV light, so it can protect the ear from harmful sun rays. You can see it just on the anterior canal wall here. And again, with dead skin, we're going to be very careful of clarinetting. So clarinetting is when you peel dead skin, sometimes it can violently flap against the suction tip, and it can be really, really noisy, not only for the patient, but also for myself performing the procedure. You generally find if you do get clarinetting with a full Zollner suction probe, that if you revert to a fine end suction tip, there's less clarinetting there. So the patient's been advised not to use not to allow water to enter the ear. They're going to use some acetic acid spray over the counter, which is designed for otitis externa, and just also recommended they use on a fortnightly basis some olive oil spray. Olive oil that's meant for the ear, so it's safely treated for the ear. And the olive oil will help moisturise the patient's dry skin. It's not the first time they've had this condition. They've come before. So this is the same patient's left ear. I would say that was semi-occluding, wasn't as occluding as the right side. And again, it's just coming out in pellets. Eardrums are intact and healthy. I think in total I've got 5 procedures. I can't fully remember what we should find out. So there's just some dead skin on the posterior superior canal wall. This type of dry wax can also be a bit uncomfortable for patients, so when they're chewing or making jaw movements, because this dry type of wax, it has a rough surface, it can abrase the ear canal wall when you're moving your jaw. So that's the patient's ear. So that eardrum was less, it didn't have a light reflex, so it was absent, you would have noticed, compared to the right. And that's just a quick overview of the dry wax. So this is patient number 2, bit of a narrower ear canal. So the wax, I would say it's still a bit dry, but it's not as dry as the previous patient. So we've got the occlusion already removed, so the patient can hear instantly, but because of the shape of the ears, it was like they got a deep valley here. So the ear canal's what we call slit, Now, everyone's ear canal, the height is greater than the width. And I would say in this patient, the height's far greater than the width. And it's just a little valley there created. And that could potentially be a cause of the patient's wax buildup. This wax is trying to come out naturally, but it's getting trapped in that valley. So we've got the occlusion out. So some dead keratin at the base of the ear canal. So you can see some of these hairs these are external hairs. And but sometimes when you go in even if you put the hair behind the ear, the suction tip does get hold of these hairs and they go inside the ear. We always see it comes out when you take the suction tip out. So just some dead skin posteriorly. So this is relatively quick procedure. And just some dead keratin superiorly. You can see this dead skin, it's slightly oxidized. It's no longer a fresh white colour, it's a bit more yellow. Now, if the patient was a bit twitchy or was finding this uncomfortable, we'll stop. We only need to kind of remove this skin in patients who are very still and comfortable. The main reason why the patient came was so we can clear their blockage, which we did almost instantly. So when we were training our ClearWex delegates, I do always advise the delegates less is more sometimes. I think I'm going to just use the Jobson horn just to see if I can just remove some of this dead skin that's on the anterior canal wall. It's a bit stubborn. Lovely healthy eardrum. So this is patient 3. This patient was really fortunate. We had a client who was meant to come from London this morning. They had a 1:30 appointment and they had the audacity to contact us at 11:30, so they should have really left by that time, if truth be told, because it's at least a 2.5 hour drive, telling us that they woke up this morning with a head cold. So our clinic opens at 9 o'clock. There was no phone call till 11:30. It's not the first time the patient's done this. I did this a couple of weeks ago. We had don't know if you're aware of the UK situation. There's a fuel shortage, inverted commas, and the patient also the day before says, he thinks they shouldn't advise against himself making the trip because there's a fuel shortage, but he could have let us know a few days before. The fuel shortage didn't happen overnight. Anyway, so because of that cancellation, this patient rang. They were really, really desperate for an appointment, and the back history is that they've had ear syringing in the past, very uncomfortable, didn't find it successful. They've been suffering from a lot of earache, went to their doctor. They've had previous childhood infections. You can see the eardrum there, it was slightly scarred. They've been using hydrogen peroxide drops, which is the worst type of drops, I feel. I'm not a big fan of it. And we managed to remove that blockage. There was a bit of dead keratin on the top part of the eardrum, which I also removed. So this is the patient. Same patient's right ear. You just see how oily and wet. They've also been using some oil. Now you can see the hammer bone, so the attic region. So at the top of the ear canal, the roof of the ear canal, the eardrum, we have a bit called the scotum. So it's the piece of bone, and it kind of angles downwards somewhat. And in people who suffer from retracted eardrums, if the eardrum sucks inwards and it wraps around that bone, and it can stop the blood flow to that piece of bone, so that bone can erode, which then enables us to see more of the eardrum and the hammer bone. So just for the audiologists out there, we could see the neck of the malleus there. So I think this is the last patient, and patient came in for a hearing test actually today, but upon examining the left ear, they had this soft debris, wax in the anterior recess, so right near the eardrum. It's right sticky stuff, and you can see the prints of the eardrum. They've got glue ear. We confirmed that not only with tympanometry, a pressure test to evaluate the impedance, so the mobility of the eardrum, but when we did a hearing test, the patient's got normal cochlear function. So the cochlea is the human organ of hearing. The cochlea is hearing fine, but the sound